Good evening, everyone. I'm Dr. Murali from India. Today, I'm going to talk about JNA resection. In JNA resection, now with the latest development of endoscopic JNA resection and co-bladder, with this, we are using modified Denker's approach, and first we are removing the medial component, medial segment of the JNA. What is medial segment? The tumor which is there in the nasal cavity, that is the medial segment, and the lateral segment is the tumor which is there in the infratemporal fossa. So the first step is modified Denker's and segmentalization. Segmentalization is what Dr. Satish Jain says is take monopolar section cautery and divide the medial segment from the lateral segment, going anteriorly to posteriorly straight away over the medial pterygoid plate. So that is segmentalization. And then removing the lateral segment by using Satish surgical's forceps, crocodile forceps, insulated crocodile forceps, and then applying monopolar. This is how Dr. Satish Jain is advocating. But recently, when we are doing a case here, we had a torrential bleeding when we removed the medial segment. We couldn't understand whether it is median artery bleeding or the sinusoidal bleeding from the JNA. Then I doubted whether this segmentalization doing initially is correct or not. There I got a doubt. Then after a lot of thought process and referring the literature, what I found is Dr. Aldo Storm from Brazil, he recommends midfacial degloving for stage 4 JNAs, which extend into the cavernous sinus and middle cranial fossa tumors. So we are replacing the midfacial degloving with modified Denker's. And first we are targeting the medial segment, that is detaching the medial segment from the lateral segment. This is where I got a doubt. And Dr. Satish Jain sir uses co-bladder for surface to control surface tumor bleeding, to prevent the fogging, to prevent oozing of the blood. Okay, that is for surface and detaching the tumor from subperiosteally in the nasopharynx in the septum area. But he is using monopolar suction cautery for segmentalization and insulated crocodile forceps to cauterize the IMAX artery. Now what I am thinking is whether this segmentalization has to be done first or cauterization of the IMAX for the lateral segment has to be done first after this torrential bleeding case. Now what I am thinking is, let us do midfacial degloving and initially target the lateral segment which is there in the infratemporal fossa and use the monopolar, crocodile, insulated crocodile forceps and cut off the IMAX vessels for the lateral segment as an initial step, the first step, and then do the segmentalization of the nasal segment, so that we can prevent the torrential bleeding when we are detaching. So this is my thought process. So finally what I came to conclusion is, always get a neck control for the external carotid, do the midfacial degloving or modified Denkers. First step is to target the IMAX vessels, cut off the IMAX vessels, cauterize the IMAX vessels to the lateral segment which is there in the infratemporal fossa, and then only do the segmentalization with monopolar suction cautery. That day when we had a torrential bleeding, we used coagulator. When I asked Satish Jain sir, what he is saying is, for segmentalization don't use the coagulator, and one must use only monopolar suction cautery. And Dr. Satish Jain advocating coagulator only for surface of the JNA and subperiosteal and subpericardial removal of the tumor from septum and the nasopharynx. So the final thing is, what I am thinking is, in an attempt to remove the tumor through the nose, only through the nose, I think we are removing the medial segment of the nose without cutting the feeding vessels to the lateral segment in the infratemporal fossa. I think that is where we got the torrential bleeding in our case. So step 1, ligation, or at least getting a control over the external carotid. Step 2, midfacial degloving in extensive nasal mass case, or in minimal case do a modified Denkers. And step 2, get a control of the cauterization of the IMAX vessels of the lateral segment. And step 3, segmentalization of the medial segment, nasal segment of the JNA. In such a situation, if we get a torrential bleeding, the only chance is median artery bleeding. That we can stop with muzzle plug from deltoid or whatever it may be, mashed muzzle directly pushing into that median canal, median artery area. That day when we had a torrential bleeding, we stopped with gel foam wrapped in Satish. I shared that technique in another video. This I learned from Satish Jain sir only. I kept 2 to 3 at that area and it stopped. So once we cut off the IMAX area to the lateral segment, I think the bleeding will be very less when we are doing segmentalization. And if at all there is a bleeding from the cavernous sinus, we can control with Satish and or gel foam wrapped in Satish. This is my thought process. Please give your opinion also. Thank you.
Hello.
Sir.
Hi, yes, Murali.
See, my doubt is, this is recording. My doubt is, you are advocating Denkers and then segmentalization with the monopolar suction cautery exactly in line to medial pterygoid plate.
Yeah, but only after taking the vascularity in control from laterally, internal maxillary in control. Clipping or coagulation of the internal maxillary, then only. Because that can be controlled laterally once you remove the posterior wall of maxilla, posterolateral wall towards the infratemporal fossa. The JNA pushes the internal maxillary anteriorly, and there you can easily find it. So first, either clip it or coagulate it, and then segmentalization can be done if it is a big mass laterally. Segmentalization is not required always. Not always required. It is only once you have a big lateral mass that cannot be accommodated in the nasal cavity without removing the medial part.
So that means you are also advocating first cauterize the internal maxillary artery laterally and then only segmentalize.
Yes, then only, otherwise the artery will bleed like anything. Because medially this artery passes into the tumor and you cannot isolate the artery easily.
So that day...
Yeah, unless you go into the tumor. Yes, laterally the artery is outside the tumor.
Okay, that day we did that mistake. Without
I told you several times. I told you. I demonstrated one 3 days before in Srikakulam. One Jain, the same one. It was a revision case. Dr. Vidyasagar was there watching. And the same story, it was a revision case, and I don't think the much was done. But the same concept I reiterated again and again. Just first go laterally. The dankers will give you amazing exposure to go to the posterolateral wall of maxilla.
Okay.
Find the artery, coagulate it, and then you go ahead with the rest of the surgery.
That means
you devascularize the tumor first.
Okay.
Yes.
And then only segmentalization.
Yes, always.
Okay. Okay, that is very clear. That means we made a mistake that first we segmentalized it without controlling the...
Yeah, because medially, I'm telling you again, the artery laterally is outside the tumor.
Okay.
Then it enters the tumor, and medially where you segmentalize, it is the artery is passing through the core of the tumor. It's difficult to isolate without entering into the tumor, and then it is going to bleed like anything.
Okay, sir. Suppose if the nasal component is very huge, do you advocate midfacial degloving and Cardwell-Lack and cauterizing?
Yes, can be done. See, I don't say that endoscopy is the only approach. Every approach has its own advantages and disadvantages.
Okay.
I still tell everywhere, this is our experience through which we have gone through, that every surgeon must know the open approaches to the JNA.
Right.
Whoever is, aspiring to be the endoscopic JNA surgeon must be well versed with. Certain open approaches are, must to learn. Midfacial degloving is one of them.
Yes.
Second is left foot one osteotomy.
Correct. Right.
In 10 minutes of time, you can do a left foot osteotomy type 1.
Yes.
But the whole maxilla comes down.
Yes.
And you are right onto the skull base.
Yes, correct.
And you can, realign it back without any morbidity, hardly.
Okay.
Third is lateral anatomy.
Yes.
Now, lateral anatomy is not a very popular. I would not recommend now in the present context for JNA, only lateral anatomy. Because you have to ultimately go ahead further with the lateral anatomy. Lateral anatomy alone will not give any further exposure.
Okay.
More than that, the purely endoscopy. So the third and the most important is the maxillary swing. That gives the widest exposure for any given extension of the JNA. Widest.
So this maxillary swing lateral anatomy is a must.
Yeah, maxillary swing lateral anatomy. Yes, that is a part of the approach.
Okay. So with
but see, the advantage of maxillary. See, Murali, the advantage of maxillary swing is you swing away the maxilla and you are right on to the mid as well as lateral skull base. Not only anterior but middle as well as posterior. The entire skull base in entirety is in front of you and you realign the maxilla back. Now, for the tumor extension of JNA, even deeply invading the skull base, it goes to the, sphenoid, clivus, cavernous sinus, anteriorly towards tracing the sella, laterally, entering into the temporal lobe. That is a that's a open book approach. You just open the maxilla, swing it, and in front of you, maybe parapharyngeal extension, any given extension of JNA described in the books can be removed by the maxillary swing. As simple as that. And that is one approach that has several advantages, except a scar.
Yes.
Obviously, except a scar. you can, after opening it, you can drill away any remnant of the pterygoid process under which. The best thing, you can put up your microscope. Your both hands free.
Yes.
Laterally, you can control the maxillary artery in front of you like any other vessel in the head and neck. Devascularize easily. Drill away the pterygoid. With both hands free, you can remove the tumor from the critical areas around the carotid artery. With both hands. And you can remove the tumor going intracranially with the same ease and comfort. So there cannot be any, it's a very fast approach.
Okay.
So sometimes, like in a young child with massive tumor extension, you are going endoscopic. It takes hours and hours. This is a faster approach that is very safe. Safest. Even I tell you, even for the carotid, it gives you opportunity to suture.
Okay.
There is an open space.
Okay.
You can suture even the vessels, anything you want to, with the maxillary swing. You can control all the portion of the carotid artery, including the parapharyngeal carotid artery right in front of you. You can control the petrous carotid. You can control the cavernous carotid in front of you. That gives the best opportunity to manage the carotid and all difficult extensions of JNA. And mobility, hardly anything except the scar. And precautionary, you marsupialize at the end the lacrimal duct because it is transected. So you go above and marsupialize like you do in DCR.
Yes.
And there is no other mobility, I tell you.
Can we do this maxillary swing with midfacial degloving, bilateral midfacial degloving?
Yes, midfacial degloving can be done. The problem is, Murali, there is a lot of retraction required, number one.
No.
And still you are,
Can we do maxillary swing with midfacial degloving?
No. If you retract the soft tissue from the anterior surface of maxilla, you devascularize the maxilla. In maxillary swing, all the soft tissue over the maxilla is kept intact with the vascularity coming from the maxillary, the facial artery.
Okay.
If you peel off the anterior soft tissue, like you do in the midfacial degloving, you end up devascularizing the maxilla. That cannot be done.
Okay. So, like Amit Keshari recommending or Aldosterone is recommending for stage 4 JNAs, they are advocating only midfacial degloving. So, do you think still that is not enough?
It can be, but again, it is what all you achieve after midfacial degloving, the exposure of the anterior surface of maxilla. Okay? Now, once you expose the anterior surface of maxilla, the JNA going deep. What all you have to do? You have to do a coil opening to enter into the maxillary sinus, then going behind the maxillary sinus, then going behind to the pterygoid process, and then going behind to the skull base. So it is a sort of tunnel.
Yes.
It cannot give you that much of freedom of instruments which you get with maxillary swing. Maxillary swing cannot be compared with any other technique. All techniques are inferior to maxillary swing as far as the exposure and ease is concerned, and safety. Again, midfacial is a tunnel. The deep area you are working through the opening, that is far superficial. For limited extensions, yes. For a surgeon who is not well versed with endoscopic, with a limited tumor extensions, yes, it is good. It gives you allowed to use a microscope with both hands free. You can put up a retractor with keeping both hands free. And but for deep invasion into the skull base, it is little cumbersome. Yes, you can if you are well experienced. I don't say you cannot do.
No.
But unnecessarily, keep putting yourself in trouble.
Right, understood, sir. So now I understood, sir. You are very clear.
Now I got to know. Probably you are trying to ask if a JNA extending laterally into the intertemporal fossa. That is the commonest extension. But not too much of invasion into the skull base. Midfacial, yes. After the endoscopic, I would say midfacial is the technique of choice with equivalent results, because once you remove the anterior wall, anterolateral wall of the maxilla, the whole JNA will be in front of you like lying as a snake,
Right.
and you can remove it under vision
Okay.
without using the endoscope.
Hmm.
Or if you want to use endoscope for the deeper part, you have a good access.
Yes.
For midfacial, everybody should know.
Yes.
Not only for JNA, for many other indications.
Yes. Correct. Sir. For even with the neurosurgical microscope, the assistant also can use his hands also, 4 hands, 4 eyes approach also.
Yes.
Mm.
Yeah. See, your both hands are free. Your assistant can help you with the suction, irrigation, and for the retraction also.
Yes. Yes.
You can use 5 hands. You can use 6 hands.
Yes. Correct. Correct.
That is the advantage.
Yes. Suppose if the tumor is totally obliterating the nose, instead of dentures, you suggest midfacial degloving and cauterizing.
Earlier, it was a big issue. If the tumor is, coming right anteriorly onto the nose, anterior part of the nose,
yes,
then how will you maneuver your endoscope?
Yes.
But now we have been doing that. I demonstrated in Calcutta right now, just now, 2 weeks before. Use tumor prolapsing out of the nose. So now what you can do, you can reduce the tumor size by means of a cobblator, by means of using a bipolar, and you can even segmentalize a part of it to give a lateral access for the denture.
Okay.
And then you go ahead with the similar way. But yes, the midfacial is one of the way.
Yes.
Another.
Hello?
Yes.
Midfacial is one of the way. Correct.
Yeah.
So now it is very clear, sir. Now the same thing what I thought is you are expressing the same.
Yeah, you come anytime to Jaipur and you can experience the same thing.
Yes. Thank you.
I'll keep like 2 cases simultaneously.
Right.
One will go endoscopic, and one I will keep a case suitable for midfacial.
Yes, correct.
Ideal. See now, you have to be very open. You cannot be dogmatic.
Yes.
That midfacial is good, but should be used for a particular indication.
Right.
This is a versatile approach, man. It can be used for 50 indications, midfacial.
Yes. Thank you so much.